I perform the pectoralis major tendon reconstruction with the patient in the beach chair position with them reclined at about 45 degrees with the head held in a head support as one would perform arthroscopy of the shoulder. I make a horizontal incision over the anterior part of the shoulder, just above the roof of the axilla, and I try and avoid the skin at the immediate part of the axilla, partly because it's very difficult to suture. So I do place it at least a centimetre above the anterior fold. And also, of course, this is an area of the body that harbours bacteria. And as we're putting synthetic graft in, I try and keep it away from the mouth of the axilla. I need to be able to get over laterally as far as the long head of biceps tendon, and medially as far as the bulk of the pec muscle, which invariably is quite retracted. So my incision is, as you can see in the video, and I usually use a Travers or Norfolk and Norwich retractor initially. Here you can see the pec tendon is, of course, not initially torn because it's a cadaveric demonstration, but here the pec tendon has now been transected, and I'm dissecting it out away from the deltoid superiorly. I go posteriorly, and of course you'll be down to chest wall almost posteriorly, and I lift it off such that I can get down to the bulk of the muscle. Mostly there is no tendon visible after a few weeks of the initial tear, even though there is a little bit of tendon here visible. In a traumatic situation, there will be no tendon, hence the need to use the synthetic graft. Now, as one is dissecting posteriorly behind the pec muscle, one needs to be aware of the neurovascular bundle. The pec muscle is supplied by the medial and lateral pectoral nerves that are branches of the medial and lateral cords, respectively, of the brachial plexus, and they come from superior and enter the muscle posteriorly along its posterior lateral part. The bundle is usually reasonably visible as one dissects posteriorly, as there's usually fat around the neurovascular bundle, and obviously this should be preserved. Here I'm demonstrating the long head of biceps tendon, which should be found and protected, and of course the insertion of the pec is just lateral to the long head of biceps. Here I'm using the Xiros polytape 800 by 20 millimeters, and I've got a clip at the midpoint of the tendon, and then I fold the tendon back on itself to get a stump, which I sew together with a non-absorbable braided suture. And then I have lots of limbs, half of which go posterior to the pec and half go anterior. You can see here that I'm placing the stump of the pec in the fold of the graft, and then I'm passing the tendon, the synthetic tendon, over the front and the back in order that there are limbs either side of the pec muscle. The next step is to suture these limbs into the muscle. I use a number 2 braided non-absorbable suture and make multiple passes through the pec muscle, but not tight, as I want to avoid strangulation of the muscle and necrosis. The idea being that multiple passes will mean that actually overall the anchorage on the muscle is very good. Now here, of course, the patient or the specimen we're using has a very small pec, but usually the patients that have this problem have a huge pec, and so these limbs are much more spread out than they are in this specimen. But this demonstrates how the synthetic graft is placed around the muscle. Now here I'm placing a mini Homan's retractor on the lateral aspect of the humerus in a human specimen in an operation, you're probably better using a Bristow or a standard sized Hohmann's retractor, such that you can see the shaft of the humerus. The assistant is holding the Hohmann's retractor so that I have a good view of the humerus. I'm now using a all suture anchor that requires a hole to be made in the humerus, and then the 2 to 3 millimeter all suture anchor is placed through the anterior part of the humerus and into the canal. It's important to use an all suture anchor in this situation. Composite anchors, which are used for cuff surgery that go into the tuberosity, are not suitable because they tend to break because of the cortical bone. Of course, the bone in the tuberosity is much more forgiving and will expand to take a composite anchor, but that's not the case in the shaft. So here's my 2.3 all suture anchor, which is going into the shaft. And out of that come 4 sutures, but of course, essentially, they're 2 running sutures. And you can get all suture anchors that either have needles on or not. And if your all suture anchor doesn't have needles on, as is the case in this video, you can use Mayo needles just to thread them on. So here I'm going to remove the trocar after rolling back on the all suture anchor. You can see the long-headed biceps there, just medial to where I've put the anchor, and I'm then going to give it a tug, and it's remarkably strong. I could almost pick the patient off the operating table with the degree of anchorage that I've got. I'm then going to place another anchor about an inch inferior to the first anchor, which I think replicates the natural footprint of the pec insertion. So that's the second anchor going in. I've got my sutures going superiorly from my first anchor just to keep them out of the way. And there's my second anchor placed. And the next step is to then pass those sutures through the stump of the synthetic tendon, as we're doing here, using the Mayo needle as I described previously. Sometimes I pass the sutures just medial to where I've done the non-absorbable suture in the synthetic tendon, just because I think that probably adds an extra bit of strength. But you can see how I've created a kind of parachute. Obviously, you don't want to be tying them initially. You want to pass them all first before you tie them down. And here I'm using a knot pusher to push the knots down against the humerus. Of course, in a patient this size, you could use your finger as the pusher, but usually when it's in a sports person and they've got a huge pec, then you're down a very much deeper hole. So that's why I use a knot pusher normally. So I'm using a couple of throws each side, and I flip my knot, and then I cut the sutures sequentially. You can use an arthroscopic cutter, or you can just use a blade, as I did there. You can see deltoid coming over the insertion now, and that's the pec tendon repaired. And you can see as I rotate the humerus that the pec relaxes and comes under tension. Now, post-operatively, I would recommend the patient goes into a polysling for 6 weeks and follows roughly a post-op rotator cuff repair protocol. So table slides, elbow, hand, wrist exercises. And at the 6-week mark, they can come out of the sling and start more loaded rehabilitation. At around 8 weeks, they can start to do more in the gym, including with the operated side. But I would prefer they don't do any supine bench pressing until at least 6 months after the surgery. Thank you for watching.